Please, let's welcome Jenna Bradfield Rhoton.
Hello, I'm Jenna. I'm a PA over at Ogden Clinic. Like you said, I'm in neurology with Dr. Piercy and Dr. Hammond over there. And I primarily when I started, I primarily took on headache patients, and so I see a large majority of the headache patients over there. And now it's still a good portion of my practice. So I got what's new in headache. Here's my disclosures. The majority of the new developments and meds that have come out in headache is focused on migraine, so we'll be pretty heavy talking about migraine today, but the biggest thing is recognizing migraine and knowing when to interfere and treat effectively, and then the new meds that are out. So I think we're all pretty familiar with a patient that comes in with a typically unilateral, moderate to severe throbbing headache. They probably missed work. They've probably had this a few times before. Maybe some brain fog and some nausea, vomiting, light sensitivity. The question is it migraine? And the answer is, I think, pretty obviously yes. The diagnostic criteria here for migraine, pretty straightforward. If people have 2 out of the 4 symptoms of, pulsating pain, unilateral, it's worsened by exercise, and it's pretty severe, then check, it's probably migraine. And then if they have one of the following, light, sound sensitivity, or nausea, check, it is migraine. And 30% of migraine patients have aura, and 80-90% of those patients are visual aura. So they usually have some kind of blind spot, bright spot, scotoma that they describe as like C-shaped, maybe some bright spots, some zigzag lines, and it usually spreads and evolves out of their vision and then eventually leaves. Aura can kind of be identified as a positive symptom typically, in that it's something new rather than a total loss of vision or tingling, numbness, or paresthesia is tingling rather than overt numbness, which we worry a little bit more about some kind of other deficit like a TIA or something. So another patient that we can see fairly often is one that's not quite so straightforward, but they have a lot of kind of low-grade symptoms. They have vertigo, maybe this ongoing disequilibrium, might have passed out a few times, frequent lightheadedness. Everybody in their family has stress headaches or sinus headaches, maybe some nausea, vomiting problems in the past, and then they are motion sick frequently. They can't tolerate car rides or the grocery store. These are ones that don't quite fit the criteria so well, but often, if we do the workup and there's not other contributing factors, it probably could be migraine, and these are people that if we can identify sooner and treat them like they have migraine, they can often get better. Third patient that's in front of you is a little different. They have, fever, maybe history of cancer, immunosuppression. They have more of those neurodeficits, like the negative symptoms, loss of sensation, things like that. Onset of the headache was sudden, onset over 50, and then all these P words here, like pattern change, positional component, where they bend over, stand up, and it gets worse or better, and worsened by Valsalva. They have swollen optic nerves, pregnancy, so on. These, obviously, I think, are red flags for headache. That's kind of a common acronym, SNOOP, for secondary headaches. So systemic signs, neurologic deficits, onset is sudden, onset over 50, and then all those Ps. So in this scenario, it is not migraine, and we'll just briefly touch on some of the testing. Sometimes when people come in with a headache, you can do no testing, or you can kind of throw the kitchen sink at them. But in general, with classic migraine, imaging is not usually necessary. CT head, we'll consider, if with that thunderclap headache, we're worried about a bleed or post-traumatic type of thing. In general, MRI is usually better. It can pick up more of the kind of subtleties, white matter changes, and usually it is not necessary to get contrast unless you are worried about, some demyelinating lesion, or there's something there that we want to better look at, or we want, certain cuts, like in the internal auditory canal, things like that, then we'll get contrast. And then those secondary headaches, we definitely would get an MRI. And the sudden onset headache is when we start to think about vascular causes of headache. So sudden onset, pulsatile, maybe some of that positional component, or autonomic symptoms. We want vascular studies, and I usually defer to MRA, head and neck. Head does not need contrast, but neck does, because you have thicker tissue in the neck to see through. CTA, head and neck, is also a good option. They're pretty comparable. And then occasionally when people have a prothrombotic state, where we're a little worried about some kind of clot and cerebral venous sinus thrombosis. I know back when COVID was a bit more prevalent and the COVID vaccines, that was one of the reported possible side effects. So that's when we would get an MRV. So that's MRA head with and without contrast to look at the venous vasculature. So one of the kind of takeaways whenever we talk about migraine should be how debilitating it is. And I think we all are kind of aware, but it is the second most debilitating disease in the world in terms of time lost because of the disease. Because people typically cannot function. They're missing work. They're missing all their kids' activities. And it's also expensive. So they're out of the job, and then they're also going to the ER frequently. It's one of the most common causes for ER visits. And it's common. It affects a lot of the population, 12%. And if you have a family member, your chances are even higher. So 40% chance if we have one parent, two parents, you're kind of out of luck probably. You have a 75% chance of migraine. And then other things to consider about it is that it's not always just classic migraine. There are some consequences of uncontrolled migraine. One being status migrainosis, where it just keeps going, but then at times that can also progress into like a migrainous infarction or a migraine-related seizure. Not extremely common, but there are more common migraine-related events like a syncopal event or even a some kind of functional alteration of consciousness or loss of motor control that can come when the migraine is just that severe. The other thing is it's not always just migraine. There are genetic angiopathies and other autosomal dominant disorders that can present with migraine, and usually we pick that up once we get the MRI. And then it's good to remember that people who have had some kind of insult or injury to the brain, like trauma or surgery or epilepsy with frequent seizures or encephalitis, meningitis, things like that, they probably will have migraine as a result afterwards. And so those are patients to keep an eye on after their event and try to intervene before it, takes off on them. So pathophysiology of migraine is never very exciting to talk about, but the old theory was the vasoconstriction causes aura, vasodilation causes headache, and that theory has pretty much been thrown out for this concept of cortical spreading depression. And so when we talk about a migraine attack, it comes in 4 phases. Prodrome is a day or two before, then headache phase, or then aura, then headache phase, then the postdrome. And in the prodrome, when they do functional MRI images, they will pick up that the hypothalamus becomes activated, and that's kind of the first step, and then the trigeminal nerve and the trigeminal vascular system becomes activated and starts releasing all these inflammatory mediators. And that triggers this propagating wave of depolarization that spreads across the brain. And that is the current explanation for the aura, is that as this wave travels the cortex, if it traverses an area where we can perceive it symptomatically, that is the aura. And then going forward, all those pro-inflammatory mediators, one of them being CGRP, is a pretty popular one that we're talking about lately because of all the new medications targeting towards it. It continues to increase neurogenic inflammation and exaggerated pain signaling, along with serotonin and this other peptide called PACAP, which is another one similar to CGRP that could be an interesting target for future studies and other medications. And then even after the headache works itself out, a lot of these proteins and neurotransmitters, they're still present in the brain and in the synapses, and that's where we go into the post-drome part of headache, where headache is mostly better, but they're still cognitively impaired. You know, the migraine hangover, their stomach is upset, they're dizzy, and so on. So I often have people come in and they're like, okay, but what's causing it? You know, is it the pillow that I sleep on? Is it my mold in my walls or whatever? And I tell them, no, the cause is that you have migraine, but it's often helpful to address it from a standpoint of discussing where their migraine threshold is. So yes, there's a lot of triggers and lifestyle contributors that push you closer to that threshold, and so maybe that's your pillow, but it's also your stress and your lack of sleep and everything, and your genetic predisposition will decide where that threshold is. And then if you get enough triggers working against you, you cross that line, you have migraine. And the problem can become when you're over that line too often, and at some point your brain can't quite compensate, and migraine can potentially progress, and you can start spending too much time over that line. And that's where I kind of came up with my own comparison here of like a wildfire. Something sets it off, and it can take off on you and get bigger and bigger and out of control sometimes. And at that point, we have to rein it in before we can really stop it completely. And all of those triggers, the mold in your walls and the pillows and those things, those are just fuel on the fire that keeps it going. So goal of treatment, really, the reason we treat is to get them away from that threshold and prevent things from worsening. And so we do know how debilitating migraine is. We also know that there's a lot of good treatments for it. But also we want to prevent the negative outcomes. So we do know that people with migraine have a 2 to 4 times increased risk of having white matter hyperintensities. This is a picture, it's not anything extreme, but it's a 26-year-old with 2 white matter lesions in her left frontal lobe, and most 26-year-olds should not have any type of lesion. And so whenever we see something like this should be kind of a sign that we can, that her disease could be better managed. And the other reason we want to intervene is because we want to prevent chronification. So episodic migraine can escalate into chronic migraine quite easily if you have enough of the risk factors. And one of the risk factors is a high number of headache days. So the more time you spend over that threshold, the more fuel on the fire, the more at risk you are of chronic migraine, which is 15 or more headache days a week, and at least 8 of those being with migrainous symptoms, and that going on for at least 3 months. Another big reason for chronification is overuse of our abortive medications. And so anytime patients come in and they're using, daily ibuprofen, Tylenol, Excedrin, or their butalbital medications, opioids, triptans, all of those things, they are helpful in the right circumstances, but if you are taking them daily, they are probably not helpful anymore. They are fueling the fire. And so I tell people once or twice a week is the goal for your rescue medicines. Likely, if you need more than that, then we should consider something like preventative treatments. And then also ineffective acute or abortive medicines. That's just kind of goes along with the more uncontrolled the migraine, the longer time over that threshold. And so even if people have episodic migraine, once a month or something, it's definitely beneficial to find a good abortive that shuts that down before it takes off on them. All right, so in the last few years, we've had quite a few new treatments come out for headache. These are not extremely recent, but I don't think we think of them that often, myself included. There are 5 devices that are FDA approved for migraine. The first three are approved as a preventative treatment for migraine. So you have a transcranial nerve stimulator. You also have the transcutaneous supraorbital, or the TENS unit, Cephaly. And then there's a handheld vagal nerve stimulator. That one is approved for migraine, but also for cluster and trigeminal autonomic cephalalgias. So that's kind of unique. And then the last two, remote electrical neuromodulation, that's actually a bicep cuff, interestingly. And then this trigeminal occipital nerve stimulator, those two are approved for acute treatment of migraine. And then I think we are pretty familiar with these. These are the monoclonal, CGRP monoclonal antibodies for migraine. They were the first preventative medicines that came out specifically for migraine. Arenumab is Aimovig, Firminezumab is Ajovy, and galcanezumab is Emgality. So 2018, 2019. They work quite well. They block the CGRP receptors, at least the bottom two do. Arenumab blocks the receptor. The bottom two block the ligand. They bind to the ligand and block its binding. So slight difference, but same kind of outcome at the end. And they're also quite well tolerated. Most of the anti-CGRP medicines are. The most common side effects with these by far are injection site reaction or a little rash, and then a bit of GI side effects like constipation. There are CGRP receptors in the gut that help with gut motility, and when they're blocked, you can get a little bit of a constipation, backing things up a bit. And then the other thing about CGRP medications to be aware of is it helps vasodilation, but inhibiting it does not cause vasoconstriction, which is significant. Other times when you need CGRP is like pregnancy, because CGRP helps with blood flow to the placenta, and so none of the CGRP medications are approved with pregnancy. But otherwise, these are quite helpful, once-a-month injections, generally well tolerated. And then shortly after that, 2019, lasmiditan came out, and it's an abortive medicine for migraine. And it was made to be somewhat similar to triptans, but they wanted to eliminate the vasoconstrictive effects that triptans have. So this is okay to use with cardiovascular diseases, but it does block similar receptors, serotonin receptors. And because of its mechanism of action, it can be sedating. And so on the label, no driving for 8 hours. So this is Rayvow is the trade name. And then same year, ubrogepant came out. This is Ubrelvy. This is the first oral anti-CGRP medication. It's a gepant, so it blocks the receptor, and it has a few different oral doses. Nice thing about it is, again, no cardiovascular contraindications, and huge, very helpful aspect of these medications is it doesn't cause a rebound headache or medication overuse headache. So when people are taking their ibuprofen every day and their Imitrex every other day, you can offer something like this and tell them to try to reduce those to a couple days a week and try something like this. They recently did a study about it in the prodrome phase of migraine to take prior to the headache, and it came out as significant to placebo for shutting down a lot of those prodrome symptoms and preventing some of the escalation to headache. So can be helpful in a lot of different ways. Eptinezumab, this is Vyepti, so another monoclonal antibody like the once-a-month injections, but this is an infusion every 3 months. And it comes in a couple different doses, 100 and 300 milligrams, and they recommend starting with 100 and then see how it goes, and if needed, escalate the dose the next round. Again, generally well tolerated. They kind of have marketed it for more refractory patients that have tried a lot of things, and it's still relatively newer in my practice. I have probably a handful of patients on it, and I monitor for the GI side effects, but besides that, my patients have tolerated it well. And then rimegepant, I think we're pretty familiar with this one. Nurtec came out right before COVID. It's another oral gepant, but it dissolves and it comes in a single dose, and it's a little different in that it's approved for 2 uses: acute treatment of migraine and preventative treatment. So you can take it every other day to try to prevent migraine or just as needed. And that's because it doesn't cause a rebound headache, again, or medication overuse headache. And there are some clinical trials currently ongoing for this. They're doing studies on pediatric and adolescent patients, and I know there's 2 research centers down in Salt Lake that they are accepting patient referrals to. So that will be interesting whenever that comes about. I do know that there's a decent amount of adolescents that are interested in this, that ask about this, and could be helpful. And then they did a study about breastfeeding, and less than 1% goes in the breast milk, so most likely safe to breastfeed. Atogepant, this is Qulipta, came out a year and a half ago. Another gepant that's oral, but this is the first one that is a daily medication, and it's somewhat comparable with the monoclonal antibody injections. So when people don't like the injections, or they had injection site reactions, or they're afraid of side effects from an injectable medicine, you can consider something like this. And it comes in a few different doses, which is nice, and it's also well tolerated, a little fatigue, a little stomach upset. And then 2021, dihydroergotamine nasal spray, so Trudesa. It's comparable to a previous nasal spray of DHE, which was Migranol, but they've updated the administration system. It sprays up higher into the upper sinuses and gets closer to the vasculature there, so is absorbed better. At 20 minutes, the plasma concentrations were quite similar to IV DHE, so that was significant. And then the usefulness of this medicine in the past has been for status migrainosis, do an infusion and try to shut down the migraine. And so it still is helpful in that way when someone has a migraine. Maybe they didn't take anything early enough, they're far into the attack, they could try something like this, and odds are it should be helpful. You can't use it with cardiovascular disease, but in the studies it did have hypertension, and they were okay there. And then lastly, this is the newest one. It came out in March. Zavegepant, Zavspret is going to be the trade name. It is another gepant, but it's a nasal spray. So again, it blocks the receptor, similar to those other ones, but they are hoping it will, be another option for people that maybe responded only partially to the other 2, and can be used in people that have a lot of the GI problems, vomiting. They don't tolerate oral medicines very well, and should have similar safety studies, side effects, everything. But I have not used this one yet, so we will see what people say about it. And that's the end. Any questions? Thanks.
I had a question in regards to the use of magnesium, and I've been, hearing and reading about that, and maybe you could just address that, please. Thanks.
Yeah, magnesium is one of the most common kind of supplements that we suggest for migraine, and it's there's some studies that it can even be helpful as an acute treatment, like some magnesium, even ginger. Some studies suggest it's comparable to sumatriptan in how well it works, but I usually recommend people take around 500 milligrams of magnesium daily and give it a good 4 to 6 weeks and see if they notice some improvement in their migraine. There's also other supplements like riboflavin, B2, and then coenzyme Q10, and then I always check vitamin D and B12 and try to make sure they're kind of on the higher end of the range, because it does seem that when people are deficient in those vitamins, that their nerves are just a bit more irritable and their migraine disorder is a bit harder to manage. So.
So we've all had some experience with preventive medications. What do you currently think when you think preventive medications for those with recurrent migraines?
Yeah, we still start with all the kind of classic oral preventatives, seizure medications, beta blockers, whatever. My go-tos are still topiramate, propranolol, amitriptyline, nortriptyline. They tend to be similarly effective, but it depends on the patient. You know, if we always kind of say treat the company the headache keeps. So you have high blood pressure, you have tremor, you maybe have anxiety, we try propranolol. I also think if the headache is really pounding, you know, pulsating, propranolol can be a helpful one. Classic migraine and you know, someone who kind of has everything. They have a lot of the photophobia, nausea, unilateral headache. Topiramate is still really solid. It works quite well. If they've had kidney stones, you don't want to use it. If they have worries about cognitive changes, you know, they're in their, you know, PhD or master's program at school, maybe avoid topiramate. And then amitriptyline, nortriptyline, they have a little bit of anxiety, depression. They have some sleeping problems, maybe have some peripheral neuropathy of some sort. Well, I'll go that route. So it just depends. Yeah. Okay, thank you.